Hello, my name is McCarthy, and I am this year's Hand Fellow at Carilion. And today we're going to be discussing uncommon nerve compressions of the hand and upper extremity. Here's a picture of the brachial plexus. Today we will be focusing on compression neuropathies that impact the median nerve, ulnar nerve, radial nerve, and neurogenic thoracic outlet syndrome. It's important to acknowledge the impact that external pressure can have on our nerves. Specifically, venous blood flow has been shown to be decreased with pressures of 20 to 30, whereas frank ischemia occurs at pressures of 60 to 80. There can be a blockade of axonal transport at pressures as low as 50. When there is a compression that occurs, it initially begins as a mild injury to the epineurial vessels, but subsequent edema can lead to fibrosis, further increasing the pressure on the nerve and leading to deterioration of nerve conduction. Following this slide, we will go into further detail of the uncommon compression neuropathies of the upper extremity and hand. To begin, we will focus on the unusual compression neuropathies encompassing the median nerve, specifically pronator syndrome and anterior interosseous nerve syndrome. Of note, the median nerve is comprised of branches from C5 to T1. It is formed from the terminal divisions of the medial and lateral cords, giving off no muscular branches above the elbow. At its start, it begins anterolateral to the brachial artery and then crosses from lateral to medial over the brachial artery, coursing between the biceps and the brachialis. Running along the medial aspect of the arm, between the brachialis and the intermuscular septum, it remains medial to the brachial artery. It then passes under the ligament of Struthers if present. The ligament of Struthers arises from the supracondylar process and inserts itself onto the medial epicondyle. This supracondylar process is present in less than 3% of the population. After crossing the antecubital fossa beneath the bicipital aponeurosis or lacertus fibrosus, the median nerve is medial to both the biceps tendon and the brachial artery, remaining volar to the brachialis. It then passes between the heads of the pronator teres, deep to the humeral head and superficial to the ulnar head. Following the median nerve then is deep to the proximal fibrous arch of FDS and then runs between FDS and FDP. Nearly all of the median nerve branches come off ulnarly. The one exception to this is AIN. AIN arises approximately 4 centimeters distal to the medial epicondyle and will continue between FDP and FPL and then descend on the volar surface of the interosseous membrane associated with the anterior interosseous artery. The palmar cutaneous branch of the median nerve arises 5 centimeters proximal to the transverse carpal ligament and then will provide sensation to the thenar eminence region. This slide demonstrates the motor innervation of the median nerve and the associated sensory distribution of the median nerve, both utilizing words and visualization. I thought this was an interesting picture depicting the topographical arrangement of the median nerve as it progresses distally through the forearm and ultimately into the hand and fingers. So to begin, we will discuss pronator syndrome, which is a compressive neuropathy of the median nerve at the level of the elbow. It most commonly refers to compression of the median nerve as it passes between the two heads of the pronator muscle or under the edge of the proximal FDS arch. It occurs in less than 1 per 100,000 persons annually. It is more common in females in their 5th decade of life, and a risk factor for this is weightlifting due to the bulk of musculature associated with the flexor pronator mass. Associated conditions to be aware of when evaluating a patient for pronator syndrome is medial epicondylitis. There are 5 potential sites of entrapment of the median nerve. We'll go through these in a proximal to distal fashion. To begin, it is the ligament of Struthers, which extends from the supracondylar process to the medial epicondyle. This is not to be confused with the arcade of Struthers, which is a site of ulnar compression. It can then be compressed underneath the bicipital aponeurosis or lacertus fibrosus, between the pronator heads, beneath the FDS aponeurotic arch, or by an anomalous muscle called the Ganser muscle, which is a common finding actually. It's found in approximately 50% of cadavers. The images here display the 5 different potential sites of entrapment for the median nerve. And again, 2 further images depicting potential sites of entrapment for the median nerve about the elbow. How does pronator syndrome present itself? It most often presents itself with paresthesias in the thumb, index, middle, and radial half of the ring finger. These paresthesias are exacerbated with repetitive pronosupination. There is an aching pain associated with the proximal volar aspect of the forearm. A key differentiating factor of pronator syndrome from carpal tunnel is that the sensory disturbance will also incorporate the region innervated by the palmar cutaneous branch of the median nerve. Because there is no associated issue with the carpal tunnel, patients tend not to have nighttime symptoms. That is because nighttime symptoms are often reflective of the flexed wrist position that tends to occur with sleep. And since there is no compression at the site of the wrist, there will also be no associated Tinel sign. There are a number of provocative tests that can be utilized to identify pronator syndrome, and each of these provocative tests is associated with a potential area of entrapment. The patient may have tenderness over the pronator teres. There can be a Tinel sign associated with the proximal volar aspect of the forearm. Again, no Tinel sign at the level of the wrist, which would be expected with carpal tunnel syndrome. There is pain with resisted elbow flexion with forearm supination, secondary to compression by the bicipital aponeurosis. There can be pain with resisted forearm pronation with the elbow extended, secondary to compression by the 2 heads of the pronator teres. And there can be discomfort with resisted contraction of the middle finger FDS, secondary to compression of the FDS fibrous arch. The utilization of imaging studies and electrodiagnostic studies are limited in the presentation of pronator syndrome. X-rays would be the most effective imaging entity to obtain to evaluate for the presence of a supracondylar process. And given the lack of associated motor symptoms, EMGs or nerve conduction studies tend to be inconclusive. So how do we treat pronator syndrome? The first option is to proceed with non-operative management. Conservative management tends to be effective in 50 to 70% of patients. It involves rest, splinting to avoid forearm rotation, and utilization of anti-inflammatories as necessary. If non-operative treatment modalities are ineffective for at least 6 months, though there is no consensus for timeline or duration of non-operative management, then you can consider operative intervention. You could also consider operative intervention if there is a space-occupying lesion that has been identified that is leading to the development of pronator syndrome. For surgical intervention, the goal of surgery is to decompress the median nerve at all 5 potential sites. If a patient undergoes surgical intervention for their pronator syndrome, up to 90% of patients have relief. Again, it is essential that you decompress the nerve at all 5 sites, which is beneath the ligament of Struthers, the lacertus fibrosus, between the heads of the pronator teres, beneath the FDS aponeurotic arch, and if there is an associated Ganser muscle. Next, we will discuss AIN, compressive neuropathy, which is the compression of the terminal motor branch of the median nerve. The AIN motor branch arises from the median nerve approximately 4 centimeters distal to the medial epicondyle. Of note, this is one of the only branches that comes off of the radial aspect of the median nerve. It then travels distally between the FDS and FDP tendons, then between FPL and FDP until it ultimately lies along the anterior surface of the interosseous membrane, traveling with the anterior interosseous artery. Ultimately, it provides sensation to the joint capsule and the intercarpal, radiocarpal, and DRUJ. For motor innervation, it provides innervation to the FDP musculature of the index and middle fingers, FPL, and pronator quadratus. AIN compressive neuropathy comprises less than 1% of median nerve neuropathies. The potential sites of AIN entrapment include the tendinous edge of the deep head of the pronator teres. This is the most common location. The fibrous arch of the FDS, a thrombosed radial ulnar or anterior interosseous artery, an accessory head of the FPL or the Ganser muscle, accessory muscles extending from the FDS to the FDP, and aberrant musculature including a flexor carpi radialis brevis or a palmaris profundus. Clinical correlates to be aware of when evaluating for AIN compressive neuropathy include a Martin-Gruber anastomosis. This is an anomalous anatomic structure that occurs in about 15% of the population. This is when axons from the AIN cross over and connect to the ulnar nerve, meaning that individuals with AIN compressive neuropathy may not only have motor weakness impacting the FDP of the index and middle fingers, FPL, and pronator quadratus, but they may also have intrinsic weakness, as the AIN contributions to the ulnar nerve provide innervation to the adductor pollicis and dorsal interossei primarily. An additional correlate to be aware of is patients who present with bilateral symptoms consistent with AIN compressive neuropathy. In those individuals, you should be concerned about a Parsonage-Turner syndrome, which is the result of a brachial neuritis. Triggers for Parsonage-Turner syndrome include a viral illness, immunizations, perioperative or peripartum state, and strenuous exercise. There needs to be a high suspicion for this underlying diagnosis, and it often is preceded by intense pain or a viral prodrome prior to onset of symptoms more consistent with AIN compressive neuropathy. How does AIN compressive neuropathy present? Generally, patients complain of vague, deep forearm pain, and they have motor deficits without associated sensory loss. On physical exam, their motor deficits generally present as weakness of grip and pinch, specifically involving the thumb, index, and middle finger flexion. They will have weakness and resisted pronation. Due to this weakness, they are unable to make an OK sign, as demonstrated in the image at the bottom right of this slide. They rely more heavily on their first dorsal interossei and their adductor pollicis in order to compensate for the weakness of their FDP and FPL. Again, this is without sensory loss, so they should have a normal median sensory exam. Additional imaging that can be obtained in the setting of AIN compressive neuropathy is an MRI. You can start to see alterations in signal intensity as early as 4 days after onset. MRI is generally utilized to rule out an associated compressive mass, and what you may find is increased signal in the musculature associated with AIN innervation. The most reliable finding is edema within the pronator quadratus. With regards to EMG or nerve conduction studies, again, you will notice abnormalities in the FPL and the FDP to the index and middle finger. These abnormalities can be represented by fibrillations, sharp waves, or an abnormal latency. With regards to treatment, non-operative intervention is the most commonly utilized, and it should be the first-line treatment for all patients in the absence of a space-occupying mass. This is done with observation, rest, and physical therapy. The majority of patients will improve with non-operative management. Often you begin to see symptom resolution between 3 and 12 months from onset, with full recovery taking up to 18 months. Average full recovery is 9 months. The reason non-operative management is so focal to treatment of AIN compressive neuropathy is that studies have demonstrated, specifically in patients that are less than 40, that almost all of these patients will uniformly respond to non-operative management. Given the significant success associated with non-operative management, surgical intervention is often delayed for at least 12 months prior to considering operative treatment, or it can be addressed in a more expedient fashion if there is a space-occupying mass that is identified and is leading to the development of the AIN compressive neuropathy. How do you do this? This surgical procedure, very similar to the pronator syndrome release, is based on a lazy S incision that allows for exploration of the proximal aspect of the median nerve. The key is to ensure that the AIN is fully visualized from proximal to distal. Again, you need to ensure that all potential sites of compression are released, including detachment of the superficial head of the pronator teres, release of the lacertus fibrosus, decompression of the superficial arch of the FDS, mobilization of the Ganser muscle, and ligation of any crossing vessels. For patients that undergo surgical intervention, there is a approximately 75% success rate with surgical treatment. We will now discuss uncommon compressive neuropathies associated with the ulnar nerve. The ulnar nerve is composed of contributions from the C8 and T1 nerve roots. It arises from the medial cord of the brachial plexus. It travels in the upper arm posterior to the medial intermuscular septum and anterior to the medial head of the triceps. It then transects the intermuscular septum approximately 10 centimeters proximal to the medial epicondyle. It is then covered by the arcade of Struthers, approximately 8 centimeters proximal to the medial epicondyle. It will then pass medial to the medial head of the triceps and posterior to the medial epicondyle through the cubital tunnel and enter the forearm through the aponeurosis of the two heads of the FCU and continue to travel medially to the ulnar artery between the FCU and FDP musculature. This slide depicts the ulnar nerve innervations, both its motor and sensory components. The less common compressive neuropathy we will address associated with the ulnar nerve is ulnar tunnel syndrome, which is compression of the ulnar nerve in Guillon's canal. Guillon's canal is approximately 4 centimeters long. It begins at the proximal extent of the transverse carpal ligament and ends at the aponeurotic arch of the hypothenar muscles. It contains the ulnar nerve as it bifurcates into the superficial sensory and the deep motor branches, and the ulnar artery. The ulnar nerve lies deep and ulnar to the ulnar artery. This slide demonstrates the boundaries of Guillon's canal. The ulnar nerve, as it travels through Guillen's canal, is separated into 3 zones. Zone 1 represents the ulnar nerve proper prior to its bifurcation. Zone 2 represents the motor-only contribution of the deep motor branch, and Zone 3 is the superficial ulnar branch. The deep branch of the ulnar nerve is the motor contribution, and it innervates all the interossei muscles and the 3rd and 4th lumbricals, in addition to innervation of the hypothenar musculature, the adductor pollicis, and the medial or deep head of the flexor pollicis brevis. This is an extensive list of potential causes of ulnar nerve compression. The most frequently encountered one is the ganglion cyst, which accounts for 80% of non-traumatic causes of ulnar tunnel syndrome. As previously mentioned, Guillen's canal is separated into 3 distinct zones. The location of compression therefore impacts the type of presentation that will be obvious on physical exam. In ulnar tunnel syndrome, when there is a sensory component, it tends to encompass the ulnar 1.5 digits. There is no associated deficit on the dorsal and ulnar portion of the hand, as can be seen in cubital tunnel syndrome. There is weakness to the intrinsic musculature, the FDP to the ring and small fingers, and the thumb adductor. There is no motor deficit associated with the extrinsic ulnar innervated muscles. There is more clawing evident in ulnar tunnel syndrome in comparison to cubital tunnel syndrome. This is secondary to the loss of intrinsics. There is associated weakness of both grasp and pinch. And there are positive Froment, Gene, and Wartenberg signs, which will be demonstrated in the next slide. This slide depicts the positive Froment's and Wartenberg sign, as seen in the top 2 images, secondary to the loss of the thumb adductor and interossei. A patient is unable to maintain possession of a piece of paper placed between their thumb and index finger without utilizing their FDP to the index and their FPL, which is innervated by the AIN. The bottom picture demonstrates a positive Wartenberg sign, which is secondary to the loss of intrinsics. And the Gene sign, which does not have an associated picture here, is a loss of the natural contour of the hand arch, secondary to the loss of intrinsics. With regards to further evaluation of ulnar tunnel syndrome, that is dependent upon your physical exam and what are potential underlying etiologies contributing to the presentation of ulnar tunnel syndrome. If you are concerned for a hook of the hamate fracture, you would obtain an X-ray or a CT scan for further evaluation. If there is concern for a ganglion cyst, one would obtain an MRI. Remember that 80% of non-traumatic causes of ulnar tunnel syndrome are secondary to a ganglion cyst. If there is concern for an ulnar artery thrombosis or aneurysm, one would obtain a Doppler ultrasound or arteriogram for further evaluation. With regards to nerve conduction studies, the threshold for diagnosis would be a decreased conduction velocity across the wrist and decreased amplitudes with regards to both the sensory nerve action potentials and compound muscle action potentials. With regards to treatment of ulnar tunnel syndrome, first-line treatment involves non-operative management in the form of activity modification, splinting, or utilization of anti-inflammatories. With regards to operative intervention, that is dependent upon the clinical presentation. One option is local decompression, which is indicated if the patient has been non-responsive to non-operative management, if the patient has an identifiable cause for their ulnar tunnel syndrome, or if there is muscle weakness noted on presentation. Techniques involved for local decompression are dependent upon the underlying cause of the patient's ulnar tunnel syndrome, such as if the patient has a ganglion cyst, then the ganglion cyst would need to be excised. If there is an associated hook of hamate fracture, that hook of hamate should be resected. If there is an underlying vascular etiology, that should be identified. For individuals with a more significant presentation that is unlikely to improve with simple local decompression, the physician can consider initial tendon transfers to address the clinical presentation, which may include correction of the clawed fingers, addressing the loss of power pinch, and improvement in a patient's Wartenberg sign. Next, we will discuss the unusual compression neuropathies impacting the radial nerve. The radial nerve is comprised of contributions from C5 to C8. It comprises the posterior cord. It begins its course posterior to the axillary artery and travels through the triangular interval. It spirals around the posterior aspect of the humerus along the spiral groove, accompanied by the profundae brachii artery. It will traverse from the posterior compartment of the arm into the anterior compartment, piercing through the lateral intermuscular septum about 10 centimeters proximal to the distal humerus. It will then reside between the brachialis and brachioradialis, 2 centimeters proximal to the distal humerus, where it will cross anterior to the lateral epicondyle. It then divides into its deep branch, or PIN, and superficial branch, superficial radial nerve, 3 to 4 centimeters proximal to the leading edge of the supinator. The PIN will course deep beneath the supinator, while the superficial radial sensory will travel anteriorly on the undersurface of the brachioradialis. It will then continue distally beneath the brachioradialis until approximately 9 centimeters proximal to the radial styloid, where the SRN becomes a subcutaneous structure traveling between the brachioradialis and the ECRL tendons. Similar to the start of each new section, this slide will demonstrate the motor and sensory innervation associated with the radial nerve. To begin, we will discuss radial tunnel syndrome. This is a rare occurrence, occurring only 3 times per 100,000 people. It is more common in males, and it has the same sites of compression as are found in PIN syndrome. The radial tunnel itself is 5 centimeters in length. It extends from the level of the radiocapitellar joint distally past the proximal edge of the supinator. Its boundaries are the following: laterally, the brachioradialis, ECRL, and HCRB. Medially, the biceps tendon and brachialis. The floor is the capsule of the radiocapitellar joint. The areas of compression have the mnemonic of fleas, which we will go into subsequently. These images below are representative of the compression sites associated with radial tunnel syndrome and PIN syndrome. They go with a mnemonic of fleas. F for fibrous bands anterior to the radiocapitellar joint. L for the leash of Henry, or radial recurrent vessels. E for the medial edge of ECRB. A for the arcade of Frosch, which is the proximal aponeurotic / tendinous edge of the supinator. And S, which is the distal edge of the superficial layer of the supinator. So the arcade of Frosch lies about 1 centimeter distal to the leading edge of ECRB. The arcade of Frosch is the most frequent site of entrapment of the PIN. What's interesting to note is that the normal pressure within the radial tunnel is about 50 However, with forced wrist flexion, that pressure can increase physiologically to 250. When looking and trying to distinguish different entities associated with the lateral aspect of the elbow, it is important when evaluating for radial tunnel syndrome to consider lateral epicondylitis. It is often difficult to distinguish the two and can coexist in up to 5% of patients. Symptoms associated with radial tunnel syndrome include a deep aching sensation along the dorsal radial proximal forearm. This deep aching sensation is about 3 to 5 centimeters distal to the lateral epicondyle. The location of this discomfort is an essential element to distinguish between radial tunnel syndrome and lateral epicondylitis. The pain associated with the dorsal radial proximal forearm increases with forearm rotation and lifting activities. There is no associated sensory deficit. However, there can be some muscle weakness on evaluation, and it is important to note that this muscle weakness is secondary to pain. It is not secondary to muscle denervation. There are no motor manifestations specifically associated with radial tunnel syndrome. Some provocative tests to evoke that proximal forearm discomfort is resisting long finger extension, resisted supination with the elbow and wrist and extension, passive pronation with wrist flexion, and then ultimately a radial tunnel injection. That injection is diagnostic if it leads to a PIN palsy and relieves the patient's symptoms. With regards to imaging, there are no specific x-rays associated with diagnosis of radial tunnel syndrome. If one is to obtain an MRI, these are usually negative. However, there are several entities that may be identified on MRI. One is denervation edema or atrophy associated with the muscles innervated by the PIN. You may note some abnormalities associated with the known compression sites, such as a thickened edge of ECRB, prominent leash of Henry, or swelling of the PIN itself. And lastly, may identify some other causes of entrapment, such as tumors or bursitis or other anatomic variations leading to entrapment. With regards to EMG/NCS testing, this is often inconclusive. That is because the PIN carries unmyelinated group 4 fibers, which are C fibers responsible for nociception, and small myelinated group 2A afferent fibers, which are responsible for temperature. Unfortunately, the symptoms associated with radial tunnel syndrome are secondary to pressure on these fibers, which lead to the diagnostic pain, but these fibers cannot be evaluated on EMG or nerve conduction studies because EMGs specifically look at large myelinated fibers, which will remain normal. And lastly, as a reminder, you can perform a diagnostic injection into the area of tenderness. That area of tenderness should be about 3 to 5 centimeters distal to the lateral epicondyle. That distal location of the pain is a critical entity to acknowledge to help distinguish radial tunnel syndrome from lateral epicondylitis. And in order for a diagnostic injection to be positive, it not only needs to relieve the patient's symptoms, but it also needs to result in a PIN palsy, indicating that the injection was performed in the correct anatomic location. With regards to treatment of radial tunnel syndrome, the first line of treatment is non-operative management in the form of activity modification, splinting, or NSAIDs. The goal is to avoid prolonged elbow extension with forearm pronation and wrist flexion. And additionally, you can utilize a corticosteroid injection, which is both diagnostic and therapeutic for individuals that undergo a corticosteroid injection. 70% note improvement at 6 weeks, and 60% of these individuals will remain symptom-free at 2 years. When to transition from non-operative management to operative management is really an unknown entity. However, studies recommend extensive non-operative treatment prior to proceeding with surgery. Surgery does offer variable results, with reports ranging from 50 to 90% of patients having good to excellent post-operative results. There can be delayed recovery up to 18 months following surgical intervention, and the results of surgery are decreased for individuals that have associated entrapment neuropathies, concomitant lateral epicondylitis, or fall into the workers' compensation category. These images depict intraoperative pictures of a radial tunnel release. In order to perform a radial tunnel release, a longitudinal or lazy S-type incision is centered over the mobile wad, starting just distal to the radial aspect of the elbow flexion crease. You then will identify the fascial stripe separating the ECRL and brachioradialis. Utilizing that interval, you will then come down onto the 5 compression sites for the radial nerve, which again are the fleas mnemonic, consistent with the fibrous bands associated with the anterior aspect of the radiocapitellar joint, the leash of Henry, the leading edge of the ECRB, the arcade of Frosch, which is the most common site of entrapment for the PIN, and the distal aspect of the supinator muscle. All 5 of those compression points must be released. Next, we will discuss PIN compression syndrome. Again, this is another rare entity. It is more common in manual laborers, males, and bodybuilders. For mechanisms of injury, it can be secondary to microtrauma as a result of repetitive pronosupination movements, occur secondary to a trauma, be a result of entrapment by space-filling lesions. A lipoma is the most commonly reported tumor associated with PIN syndrome. It can also result from synovitis associated with rheumatoid, or it can be iatrogenic as a result of surgery. Here is a depiction of the course of the PIN. The PIN passes under the arcade of Frosch, which is that leading aponeurotic edge of the supinator, between the 2 heads of origin of the supinator muscle. It will make direct contact with the radial neck and then pass over the abductor pollicis longus in order to reach the interosseous membrane, where it will traverse distally along with the posterior interosseous artery. It is important to think about which region of compression is occurring and the resulting clinical picture. If the medial branch of the PIN is compressed, it will result in weakness of the ECU, EDM, and EDC musculature, while compression of the lateral branch will result in weakness of the APL, EPB, EPL, and EIP musculature. Identical to radial tunnel syndrome, PIN compression syndrome has 5 potential sites of compression, which is represented by the mnemonic fleas, standing for F, the fibrous tissue anterior to the radiocapitellar joint, L for leash of Henry, E for that leading edge of the ECRB, A for the arcade of Frosch, which is the proximal edge of the superficial portion of the supinator, and S for the distal aspect of the supinator. Symptoms associated with PIN compression. It is of insidious onset without any associated sensory deficit. There is pain in the forearm and wrist, specifically with resisted supination, and there is associated muscular weakness involving the finger, wrist, and thumbs. Chronic compression of the PIN may cause extensor compartment muscle atrophy. As a result of this weakness, patients will note difficulty with finger and thumb extension. On clinical exam, that will be seen as an inability to actively extend the MCP joints. With regards to wrist extension weakness, it is important to note that because the ECRL is innervated by the radial nerve proper, the patient will still be able to extend their wrist. However, there will be radial deviation associated with extension. Due to PIN innervating the ECU, there will be an inability to extend the wrist in neutral or ulnar deviation. As a clinical note, the ECRB tends to be innervated by a branch of the radial nerve of its own. There is no imaging modality recommended for diagnosis of PIN compression syndrome. However, if one were to obtain advanced imaging, an MRI may be able to help localize and delineate a soft tissue mass responsible for compression. As previously noted, a lipoma is the most common soft tissue mass associated with PIN compression. With regards to EMG and nerve conduction studies, these are usually positive. That is secondary to the compression affecting the large myelinated fibers of the nerve, which are what are detected on EMG or nerve conduction studies. Non-operative management is recommended as the first-line treatment for all cases in the form of rest, activity modification, stretching, splinting, and NSAIDs. For individuals where initial non-invasive non-operative management is ineffective and a compressive mass has been ruled out, one can trial a lidocaine or corticosteroid injection. This should be injected 3 to 4 centimeters distal to the lateral epicondyle in accordance with the radial tunnel space. When thinking about non-operative management of PIN compression, it is important to note that 75 to 97% of non-traumatic cases undergo spontaneous recovery. However, if there is no improvement in motor dysfunction by about 3 months, spontaneous recovery is not likely. And it is important to not wait with PIN syndrome for too long, because if PIN syndrome is neglected for about 18 months, the muscles innervated by the PIN will undergo fibrosis, leaving tendon transfers as the only viable surgical option. When non-operative management has been unsuccessful, specifically after 3 months, where it is unlikely for spontaneous recovery to occur, or when a compressive mass has been detected, the patient should undergo a technique as previously demonstrated with the radial tunnel syndrome and decompress all 5 compression sites associated with PIN compression syndrome. The outcomes of surgical decompression are variable, and the patient may continue to improve for up to 18 months following surgical intervention. For our last radial nerve associated compressive neuropathy, we will discuss Wartenberg syndrome. This is a compressive neuropathy of the superficial sensory radial nerve at the wrist. It is compressed by the scissoring action of the brachioradialis and ECRL tendons during forearm pronation. Harkening back to our anatomy discussion, you'll remember that the superficial sensory radial nerve transitions to a subcutaneous structure about 9 centimeters proximal to the radial styloid. This is a rather uncommon entity and tends to affect females more often than males. It is important when attempting to diagnose Wartenberg syndrome to distinguish this entity from de Quervain's tenosynovitis. Again, harkening back on the Anatomy: the superficial sensory branch of the radial nerve arises at the bifurcation point of the radial nerve proximally in the forearm. It travels deep to the brachioradialis and emerges between the brachioradialis and the ECRL about 9 centimeters proximal to the radial styloid. Just proximal to the wrist, it bifurcates into its dorsal and palmar branches. Symptoms associated with Wartenberg syndrome include an ill-defined dorsal radial hand pain. This pain can be exacerbated with pressure over the junction of the brachioradialis and ECRL. Clinically, patients may report a history of handcuffs or an inability to wear a watch. They will continue to have symptoms at rest. Along with this discomfort, they will note paresthesias overlying the dorsal and radial aspect of the hand, and there will be a Tinel's sign associated with the superficial sensory radial nerve. Their symptoms are aggravated by motions involving repetitive wrist flexion and ulnar deviation or forearm pronation. It is important to listen to the clinical history and pay attention to the aggravating factors on exam, as that is critical to distinguishing this entity from de Quervain's tenosynovitis and intersection syndrome. With regards to imaging and electrodiagnostic tests, they are of limited value. As has previously been discussed, electrodiagnostic tests are of limited value secondary to the lack of large myelinated fiber involvement. One can also perform a diagnostic injection, and this may provide the patient with temporary relief. As is the theme today, the first line of treatment is non-operative management in the form of rest, activity modification, splinting, and NSAIDs. The goal is to avoid aggravating activities and to remove inciting factors. If necessary, one can trial a corticosteroid injection, but ultimately this tends to be a syndrome that does spontaneously resolve. If the patient does have persistent symptoms that do not spontaneously resolve nor respond to non-operative management, then one can consider surgical decompression. In order to do that, you will develop a longitudinal incision volar to the patient's Tinel sign. Again, that Tinel sign will be associated with the superficial sensory radial nerve. The goal of this is to avoid injury to that superficial radial nerve and to avoid injury to the lateral antebrachial cutaneous nerve. Once you have made that incision, you will neurolyse and release the fascia between the brachioradialis and the ECRL, where that superficial radial nerve is transitioning to its superficial position. Overall, this decompression has about a 74% success rate. Finally, we will discuss thoracic outlet syndrome, specifically neurogenic thoracic outlet syndrome. As will be highlighted later on in this discussion, neurogenic thoracic outlet syndrome is a clinical research area of focus here at Carilion Clinic. To begin, thoracic outlet is defined as the interval from the supraclavicular fossa to the axilla that passes between the clavicle and the first rib, containing 3 important structures, including the subclavian artery and vein and brachial plexus. Thoracic outlet syndrome impacts 1 to 2% of the population and is notably more common in females than males. Patients tend to have thin, long necks with drooping shoulders. There are several types of thoracic outlet syndrome, including neurogenic versus vascular, and vascular is broken down into venous and arterial. By far, neurogenic is the most common form of thoracic outlet syndrome. This picture depicts the 3 distinct spaces that comprise the thoracic outlet. The first one is the inner scalene triangle. It is the most proximal space. It is bordered anteriorly by the anterior scalene, posteriorly by the middle scalene, and inferiorly by the first rib. It contains the brachial plexus trunks and the subclavian artery. The subclavian vein does not pass through the inner scalene triangle. Rather, it runs beneath the anterior scalene muscle prior to entering the costoclavicular space. Now, the costoclavicular space is the middle space. It is separated from the inner scalene triangle by the first rib. Its borders are anteriorly the clavicle and subclavius muscle, posteriorly the first rib and scalene muscles, medially the costoclavicular ligament, and laterally the upper scapular border. It contains the brachial plexus divisions and the subclavian artery and vein. Finally is the retropectoralis minor space. This is the most distal space, otherwise known as the thoraco-coracopectoral space or subcoracoid space. It is bordered superiorly by the coracoid, anteriorly by the pectoralis minor muscle, and posteriorly by 2 through 4 ribs. It contains the cords of the brachial plexus and the axillary artery and vein. Most cases of thoracic outlet syndrome stem from an anatomic predisposition with a superimposed neck trauma. This anatomic predisposition can either be a soft tissue or an osseous abnormality, where soft tissue abnormalities are the more commonly encountered entity. Muscular trauma can consist of injury to the scalene or pectoralis minor muscles, leading to possible tearing, fibrosis, contraction, or hypertrophy. It is hypothesized that these elastic changes to the muscle fibers contribute to the dynamic compression of the neurologic structures. Additionally, chronic poor posture, which is characterized as a forward head position and rounded shoulders, can induce chronic scalene muscle shortening, leading to a pathologic contraction. As previously mentioned, soft tissue abnormalities can contribute to the development of thoracic outlet syndrome. Scalene muscle abnormalities can include hypertrophy of the anterior scalene, an abnormal passage of the brachial plexus through the anterior scalene rather than the inner scalene triangle, variable origins and insertions of the scalene musculature, or an accessory muscle called the scalenus minimus, which originates from the cervical transverse process and inserts onto the first rib between the subclavian artery and the T1 root. Additional soft tissue abnormalities can include anomalies, ligaments or bands, soft tissue tumors, or an abnormal pectoralis minor. With regards to osseous abnormalities, there could be a cervical rib, which occurs in less than 1% of the population and arises from the 7th cervical vertebra. One may have a prominent C7 transverse process, an abnormal clavicle or first rib, an injury to the AC or SC joint, or an osseous tumor. Timing of presentation of thoracic outlet syndrome is determined by the underlying etiology leading to the syndrome. There can be delayed symptoms after an acute trauma. It can occur after chronic overuse, or could be the result of a repetitive compression over time leading to vascular TOS. An interesting clinical entity. This can be found in well-developed young athletes where there is intermittent obstruction of the subclavian vein in the costoclavicular space. This intermittent obstruction can occur secondary to an abnormal costoclavicular ligament or hypertrophy of the anterior scalene muscle and result in a DVT in the upper extremity. The presentation of thoracic outlet syndrome is highly variable and dependent upon the region of compression. In the setting of neurogenic thoracic outlet syndrome, 92% of patients endorse some level of trapezial pain. The pain associated with thoracic outlet depends on which part of the plexus is impacted. For individuals having lower plexus involvement, their symptoms are more commonly in the area of the ulnar forearm and hand, while the upper plexus tends to radiate to the ipsilateral head, face, upper chest, periscapular region, or the radial nerve distribution of the dorsal index finger and thumb. Of clinical importance is that the sympathetic chain originates at the T1 level, and when TOS impacts the C8 and T1 nerve roots, there can be dysfunction in the sympathetic signaling to the upper extremities. In addition to pain, there is upper extremity weakness, numbness, and paresthesias. This occurs in a non-radicular nature. That is important to note. There can be upper extremity heaviness. Their symptoms can be activity related or occur at nighttime. And again, there may be some vasomotor changes as well. With regards to the physical exam for thoracic outlet syndrome, it is very important to begin your exam with inspection. As we had previously mentioned, posture can increase loading on the brachial plexus, so be aware of patients that have rounded shoulders, increased thoracic kyphosis, or a downward rotation or depression of the scapula. Additionally, the Gilyot-Sumner hand is a characteristic finding of neurogenic TOS and is represented by atrophy of the abductor pollicis brevis, the hypothenar musculature, and the interossei. There are several provocative tests involved in the evaluation of thoracic outlet syndrome. One is the supraclavicular pressure test. There is the Adson test, which occurs when the patient's arm is abducted 30 degrees at the shoulder and maximally extended. Then the patient extends the neck and it turns the head toward the symptomatic shoulder and is asked to take a deep breath and hold it while the examiner is palpating the radial pulse. This test, when positive, will reproduce the patient's symptoms or lead to paresthesias. There should also be a reduction in the amplitude or a loss of radial pulse. It is important to note, though, that 51% of the normal population will have a diminished pulse with the Adson maneuver. The costoclavicular maneuver occurs when the examiner is palpating the radial pulse and then draws the patient's shoulders back and down as the patient lifts their chest. A positive result occurs with a reduction in amplitude or loss of the radial pulse, or reproduction of the pain and paresthesias the patient has been experiencing. The right test is performed with the practitioner palpating the radial pulse. The arm is then passively brought into abduction and external rotation, and the elbow is flexed. A positive test again occurs if there is a reproduction of the pain or paresthesias, or a reduction in the amplitude or loss of the radial pulse. Again, 7% of the normal population, though, can have a diminished or lost radial pulse when performing the right maneuver. The Roos, or elevated arm stress test, is performed by the patient abducting and externally rotating both arms. The patient is then asked to open and close the hands slowly over a 3-minute period. This test, to be positive, will reproduce the pain or paresthesias the patient has been experiencing. Oftentimes, patients with thoracic outlet syndrome will be unable to complete this test for the extended duration. And the Sirik's release test is performed by the practitioner elevating the patient's forearms while having the trunk tilted slightly posteriorly. The elevation of the shoulder girdle is then held for up to 3 minutes, and the test is considered positive if there is reproduction of the pain or paresthesias or a positive release phenomenon that occurs at completion of the test. This slide is just another pictorial representation of some of the provocative maneuvers that are utilized to diagnose thoracic outlet syndrome. As previously mentioned, neurogenic thoracic outlet syndrome is a focus of study here at Carilion Clinic. Recently, the Carilion Clinic has published the Roanoke criteria to assist with diagnosis of neurogenic thoracic outlet syndrome. This criteria emphasizes the non-dermatomal pattern of neurologic symptoms, the presence of sympathetic symptoms and positional symptoms, and the positive results associated with injections. Here is a depiction of the Roanoke criteria, demonstrating the major, minor, and required criteria necessary to assist with diagnosing neurogenic thoracic outlet syndrome. Imaging is a critical aspect in evaluating for thoracic outlet syndrome. With regards to x-rays, it is important to evaluate for the presence of a cervical rib, a prominent C7 transverse process, a low-lying shoulder girdle, or a Pancoast tumor. Ultrasound is used to evaluate for the presence of a wedge sickle sign, which is specific for patients with lower trunk involvement. The CAT scan can be used to identify osseous space occupying lesions or malunited fractures, while an MRI can identify soft tissue anatomic anomalies contributing to compression. With regards to nerve conduction studies, only about 5% will show findings supportive of neurogenic TOS. For those that do have supportive findings, nerve fibers from C8 and T1 can show early changes in neurogenic TOS. This is represented by abnormal nerve conduction velocities in the medial antebrachial cutaneous nerve, the median motor nerve to the abductor pollicis brevis, and the ulnar motor nerve to the first dorsal interossei. I know that was a very brief overview of the vast and variable potential presentations of neurogenic thoracic outlet syndrome. However, thoracic outlet syndrome could be a talk entirely of its own. I just wanted to make sure that thoracic outlet syndrome was highlighted here so that it becomes a more commonly thought of entity for upper extremity surgeons as we are considering potential uncommon compressive neuropathies for our patients. We will now transition into briefly addressing the treatment modalities available for thoracic outlet syndrome. First and foremost, we begin treating our patients non-operatively in the form of activity modification, pain control modalities, and physical therapy. Therapy primarily focuses on extending shortened scalene and pectoralis minor muscles and improving arm posture, utilizing scapular stabilizing exercises. Additionally, besides focusing on the shoulder and neck musculature, they will work on strengthening the core to prevent overuse injuries. Therapy tends to be less successful in patients who are obese, are on workers' compensation, or those who have double crush phenomenon. Additionally, physicians can trial anterior scalene or pectoralis minor blocks. These injections are indicated for neurogenic TOS patients with symptoms related either to the anterior scalene or the pectoralis minor muscle contracture. For patients that have had a successful block, that correlates with a 14% higher rate of good surgical outcomes. In patients who have had a good response to local blocks of either the anterior scalene or pectoralis minor, can consider an ultrasound-guided botulinum injection. Those injections provide some longer-term relief than our lidocaine injections, and 69% of patients did note short-term improvement in their symptoms. When patients have persistent symptoms despite conservative management, or they have progressive muscle atrophy and or worsening neurologic deficits, one needs to consider thoracic outlet decompression. There are several approaches to thoracic outlet decompression, which is based upon surgeon experience and preference. The approaches include transaxillary, supraclavicular, and posterior. Here at Carilion Clinic, we prefer supraclavicular, which provides a more favorable exposure to the upper brachial plexus, the neck of the first rib, and the associated neurovasculature. With regards to thoracic outlet decompression technique, the technique employed is highly dependent upon the underlying etiology of the patient's symptoms. The technique can involve a variety of options, including first rib resection, anterior/middle scalenectomy, brachial plexus neurolysis, isolated pectoralis minor tenotomy. With regards to the treatment provided here at Carilion Clinic, one of the more common techniques employed is neurolysis of the brachial plexus and an isolated scalenectomy. A meta-analysis performed in 2023 revealed that the isolated scalenectomy was the most effective treatment in terms of patient outcomes and complication rates. For patients that have etiology isolated to the pectoralis minor, if an isolated pectoralis minor tenotomy is performed, the success rates varied from 72 to 75%. With regards to complications associated with decompression, the most common complication encountered is a pneumothorax. Additional complications include injury to the subclavian artery or vein, damage to the brachial plexus or thoracic duct, and a failure to fully decompress the thoracic outlet. Thank you all for hanging in there with me while we covered some of the uncommon upper extremity compression neuropathies. Again, this was a brief highlight of the broad spectrum of uncommon neuropathies that the upper extremity surgeon can encounter, and it is important for physicians to keep a broad mind with regards to potential diagnoses and really pay attention to the patient's history and the associated clinical exam to help guide us to the appropriate diagnosis. Again, thank you for your time today, and I hope everyone has a great rest of their day.